But how's it going, everybody? I hope you're all having a great week so far. I know a lot of people are kind of like in their finals week of the fall semester. So if that's you, thank you so much for joining us. Today we're going to be talking about a orthopedics topic. We're going to go over a couple different types of sports injuries. And for those of you who are new to virtual rounds, my name is Olivia. I'm a fourth year medical student at the University of Iowa, Carver College of Medicine, and I'm currently applying in the match this year for anesthesiology. So ortho, I think, was one of those topics that somebody had requested in the feedback of the SOAP note form that we send out every week or every time we do virtual rounds. And I will admit that this was a little bit out of my typical arsenal of what I'm comfortable with, because musculoskeletal anatomy and everything is really something that I'm not like super passionate about. And I had to text my ortho friend for a couple questions, but I think we've got a really solid case today, and hopefully this can just add to the variety of things that you've seen in medicine. So we'll start with our patient case. We will go through a patient physical exam. That's kind of a really important bulk of today's talk, because physical exam is super important in diagnosing musculoskeletal and sports injuries. Go through a differential diagnosis, talk about our assessment and plan for our patient, and then talk a little bit about the anatomy and pathology of disease. It's not really like a diseased state necessarily in a lot of sports injuries. It's just like a mechanical or traumatic thing that happens. So it's not like a really intricate pathophysiology, but you have to definitely have like that knowledge of anatomy and ways that we can try to help make the patient more comfortable. So please feel free to ask questions, unmute yourself, ask questions in the chat, or if other people have questions, you can feel free to like take a stab at it and contribute anything in your experience or from your knowledge. And I did also attach the link to the SOAP note and quiz form in the chat. So hopefully you guys can access that. And if you have any difficulties, just let me know. So we have a 17-year-old male patient who is presenting to our urgent care with a chief complaint of right-sided knee pain after one day after sustaining an injury at his high school basketball practice. So pretty typical picture, patient that, maybe like went home and thought that it was going to get better and didn't go to the emergency room right away. So that can kind of tell you some things about like how severe it might be just off this one sentence. So off the bat, without any additional information, and knowing that he got this at basketball practice, do you guys have any ideas of things that can cause knee pain? And it doesn't even have to be sports related. Like, I guess spoiler for the next slide when we have it, but like one of the things that I put on there is arthritis, and definitely unusual if a 17-year-old already had arthritis, but definitely not something to rule out at any point until we have more information. So let's try to maybe think of like three things that we can think of that can cause knee pain. Any ideas? And it doesn't have to be like a technical term either. Yeah, previous injury to the knee. So like maybe this person, like he's an athlete, he's had previous injuries before that now are just like acting up again. Or if he fell, like maybe it was just like the trauma of like falling on a hard surface and he's got like a bruise. Melina said a fracture. Perfect. That'd be a more serious one, certainly, but definitely a possibility and something that we don't want to miss for sure. Some more common things would be like a sprain, like an overextension injury that doesn't really have like anything pathologically wrong or things that we'd have to go in and fix, but can definitely cause knee pain in a patient. Some other things that are a little bit more technical, and we'll go through a lot of this in greater detail. So if these terms look unfamiliar to you, or if you're not sure like where it is in the anatomy, like we'll address a lot of this later. But some things that I came up with was like a ligament tear. So the four main ligaments in the knee are the ACL, the MCL, the LCL and the PCL. And that is the anterior, the medial, the lateral, and the posterior ligaments of the knee. And I have a picture later on that'll kind of show you like on a map or on an image where those are located. And there's certain findings with each one also depending on where it is. So those are the four main ligaments. You can have like a either partial or full tear. I'm sure you guys have all either known someone or like seen in professional athletes or college athletes, someone who has like an ACL tear and they are out for that season. But some of these other ones are not as heard of or that people don't recognize as much. I don't think I really like thought that there was anything else besides an ACL when I was before I got to medical school. Similarly, a meniscus. I don't know if I even knew what a meniscus was before I got into medical school, but you have two different meniscus structures in your knee, the medial and the lateral. So again, we'll go through like what the differences between those two different positions. And then the patella is the kneecap bone. So you can have a patellar tendinitis, which is like an inflammation of the tendon that attaches to the patella. And similarly, a bursitis. This is like an accumulation of fluid in the joint space of the patella. Dislocation, just like you would think of any other dislocation in the body, it's where the bone like pops out of its space that it's supposed to be. And sometimes you can even just visually see it with like on gross inspection. So if like your kneecap is like shifted off to the side, that can be a patellar dislocation. We did talk about fracture already as a possibility. The three bones that make up the rest of the knee joint that's not the patella is the tibia and fibula. Those are the two bones that are more in the lower leg. And then the femur is the big main thigh bone that's in the upper leg. So you could technically get a fracture in any of those bones as well as the patella. Some other things, so IT band syndrome or the iliotibial band. This might not be like as gross knee pain or as like a sudden onset as this patient who had like a definitive injury and it happened like one day ago, but this is more of like an overuse injury, especially in runners, where like kind of down the outside of your thigh, you have this really large, big ligament, and that's called your IT band, and you can have just like irritation of that. And then less likely up here, like I mentioned, the arthritis. This is something that we definitely see a lot more commonly in older people who have wear and tear in their joints and who have less cartilage present. But they are, sorry, I'm going to clear this drawing here. I don't actually know how to do that. Never mind, I think I got it. But anyways, and then an inflammatory arthritis, this would be like not just like your typical wear and tear, but something that can be a little bit more sudden onset. So you can have like a joint space infection, that's a septic arthritis, or probably the most rare for this patient who's only 17 years old, but a crystal arthritis like gout can also come on really suddenly and can cause a really painful joint. So those are some things in the differential. This is not an exhaustive list. I always say that, like, keep it really broad, throw as much of anything as you want on your differential at the very beginning, and then you can always narrow down. So some more information on the case. This patient was running down the court and he twisted suddenly and then heard a loud pop at the time of his injury. So that's an important piece of his history, right? That's like a definitive moment that happened and that there is a sound associated with it. Sometimes that's not always the case. If they had described it as like a snap or something, you might think more of like a fracture or something to do with the bones. This popping sound is associated with one of the injuries that we had on the other slide. So we'll go through that a little bit more later. But as soon as this injury happened, he was immediately painful and had trouble with weight bearing. So he stopped practice early and went home to rest his leg and to ice it and hoped that it would improve by the next day. And in that time, he's also taken 4 ibuprofen, which is the brand name Advil, pretty typical over-the-counter pain reliever drug. But he's still having his pain, and obviously as an athlete wants to get it checked out so that you can hopefully start to recover and be back to your sport. So a little bit more information, not about the history of present illness, but just about his general medical history. So he does not have any chronic illnesses or take any daily medications. The only thing that we noted, like in his chart, was that he recently recovered from mononucleosis 3 months ago. So that's a pretty typical viral infection, mono, that we see in this aged population. High school, college age kids can spread mono really easily. So he recovered from that 3 months ago and has been healthy since. And then for his family history, his father has a history of osteoarthritis of both knees. That's that sort of wear and tear, age-related arthritis. And his father manages this with naproxen and physical therapy. Naproxen is like a cousin of ibuprofen or Advil. It goes by the brand name Aleve, and it's just more of like an extended release, but it has the same mechanism. And then also he has a younger sister who has a history of an asymptomatic congenital heart defect that never required any treatment or surgery or anything like that. So that's the only family history that he has. And then for his social history, he is a senior in high school and active in both basketball and soccer. And he is planning to attend a local college to study finance next year. So always good to know a little bit of personal information about your patients. So now getting to the physical exam, this is a little bit denser of a slide than I typically like, but like I mentioned before, the physical exam in musculoskeletal injuries is really important because it can give you so much information and help to narrow down your diagnosis without having to do a ton of extensive like imaging or labs or tests or things like that. So off the bat, we're going to start with his vitals, and his vitals are looking pretty darn healthy. The one thing that you might notice is that his heart rate is a little bit lower. The normal heart rate for adults is between 60 to 100 beats per minute, and he's sitting at 50. But that phenomenon is actually common in athletes who are really active, who have very excellent cardiovascular fitness, that they can have a much lower resting heart rate than that 60 of what would be considered normal. So I wouldn't consider this to actually be unhealthy or like abnormal. This is just kind of his heart's way of having adapted to being really in shape and not having to work as hard as a typical person. But everything else looks great. His blood pressure is normal, temperature and oxygen and everything is totally within normal limits. For the rest of his exam, so like general and cardiopulmonary and abdominal, those are all just unremarkable. He looks well appearing. He's in no distress. He does have that resting bradycardia, like I had mentioned before. That's the lower heart rate, but that we aren't concerned about it because he's just a very active person. Regular rhythm, his breath sounds are clear. He has no abdominal tenderness or distension or any findings there. The interesting part is really just the rest of this, the lower extremity exam. So looking at his left side, first, it's nice to be able to have two limbs because then you can compare them to each other. His left side, which is the unaffected side, there's no skin changes, no swelling or edema over the joints. It's non-tender. He has a full strength and range of motion in his hip joint, knee joint, and ankle joint. So really completely normal and unremarkable left lower extremity. The right side, however, the one that's affected, just looking at it without even doing anything, he does already have this mild redness over the knee with a swelling, associated swelling and an infusion. So swelling is one of those things that you can just like look at and tell that the joint itself is actually bigger than the one on the other side. And it's due to an accumulation of like fluid and inflammation that happens in response to the injury. And then the effusion is fluid that builds up in the joint space. So in this case, it could even be blood from the trauma of having an internal injury. But it's basically just when you palpate the joint that you can actually kind of feel or like milk out some of the fluid from the joint space that wouldn't otherwise be there. His knee exam is also limited by pain. That's super common with these types of injuries or patients who have a specific pain complaint, that when we do parts of the exam, it can be difficult to get an accurate range of motion or strength assessment of that joint because it's just too painful and you don't want to, you don't want to put them through torture just to like get your exam. So do it within reason. The exam can be very valuable if they're willing to try to, cooperate and to kind of go to the limit of their pain, but we don't want to exaggerate the pain for no reason. So he was limited by pain, but there was no clicking or locking of the joint or joint line tenderness. And that's where, like, if you were to palpate along the side of the joint and just kind of press on it in different spaces, there's no like point tenderness on palpation, and that moving the joint, we don't notice or feel any clicking or locking. The two tests that we did here that came back positive is the Lockman test and the anterior drawer test. I have a couple of videos on the next slide that I'll play for you guys so you can see what they look like, but I just wanted to make note of that on this slide before we move on, and that these other tests, the posterior drawer test and the valgus stress test, were both negative. And the utility in doing these tests is that it can help you kind of distinguish between, like, if it's an ACL versus a PCL injury, if it's a meniscus injury, those sorts of things. So the positive ones here was the Lockman test and the anterior drawer test, and we will watch those videos right now. I don't know if you guys can hear this, but the sound isn't super important. It's just more so the visual of it.
Assessing its translation. Note that the examiner bends the knee to 90 degrees and anchors the foot using his body.
So you're going to bend for the anterior drawer test to 90 degrees.
Assessing its translation.
And then you could try to pull the leg forward.
The leg is placed in 20 to 30 degrees of flexion. A pillow may be used to help stabilize.
And for this one, the knee is bent a lot less. And you're trying to, again, pull the knee kind of forward. So that's the Lockman test and the anterior drawer test to show you kind of the difference between them. Just to summarize again, with the anterior drawer test, that one, you're bending your knee a lot more. It's at like a 90 degree, and you're trying to, with your fingers on the back of the calf, pull the leg forward. And if it moves or displaces relative to the top of the leg, then that would be positive, and that would be indicative of like an anterior injury. And then with the Lockman test, it's still assessing the same thing. It's for like an anterior ligament injury, but you're just doing a lot less of a knee bend or of a knee flexion. And that's kind of the difference between the two of them. Clinically, is my screen still full screen? I don't know if you guys are like seeing my screen. I think probably because I made it full screen. Anyways, sorry about that. That's the difference between the anterior drawer test and the Lockman test. They're both assessing for the ACL injury. And the Lockman's test is slightly more sensitive than the anterior drawer test. And I think I read that it was like 80 to 90% sensitive for diagnosing an ACL injury. So the fact that these are positive is strongly suggesting right now that they have a ACL injury. And then this is just another one to show you guys. So that's like an actual positive result. You can see that the knee itself kind of looked almost floppy, and you were able to get that extra displacement from the joint that you wouldn't otherwise have in like a normal uninjured leg. So that's what that would look like in a person who actually has that injury. And then the last one that I have a video for is the valgus stress test, and we'll watch that here. And this one is going to assess for either a medial meniscus or MCL. Both are medial side of the knee problems.
Hey everyone, Paul from Ortho Eval Pal. Today what I want to do is talk to you about the valgus, checking the capsule to see if that's holding well. You keep the knee in full extension. You basically put this hand on the lateral side of the knee. This one is stabilizing over here. And all you're doing is putting a little bit of a valgus stress. Now notice how it opens up a little bit. She does not have that on that side. So it tells me that she has a little bit of, instability at that medial capsule.
So that's the valgus stress. It's basically looking at the inside or the medial part of the knee. And if you can displace it outwardly or laterally, then that's a positive result for it, which our patient in the exam that we did, they did not have this be positive. So theirs was just a stable joint. But this was just so that you guys could see what the test is looking at and the result, like what it would look like in a real positive patient. So those are the different physical exam maneuvers that we did in this patient with like a knee complaint. And it kind of helped us narrow down that we're seeing in him an anterior displacement of the joint in the both anterior drawer test and the Lockman test, which correlates with an ACL injury. And we did not see a positive valgus stress test, which would correlate with a medial or a meniscus injury. The one that I didn't put a video on here was the posterior drawer test. It's basically the same as an anterior drawer test, like in that first video, except instead of pulling the knee towards you and trying to get it to displace anteriorly, you would be pushing it back and seeing if it displaces posteriorly, which would then correlate, as you could probably guess, with a PCL or a posterior cruciate ligament injury. It's kind of the opposite function of what an ACL would do. And I'll show some more pictures later to help it with that. But I just want you guys to take away that the tests that we did for the ACL are the Lockman test and the anterior drawer test. And then the one for the medial joint and the meniscus is the valgus stress test. And if people have questions about this, or if you want to go back and watch these videos again, I'm happy to come back to it and answer anything that you might have.
Hey everyone, Paul from Ortho.
Oh my gosh, sorry guys. So just a little bit about each different thing that we were considering. So after doing our exam, I had these three things kind of highlighted in our differential to look at. So the first one, the most likely right now being an ACL tear. ACL stands for the anterior cruciate ligament. And in patients who have a tear or an injury of the ACL, this often presents after that loud pop injury, which, remember, our patient said that they heard during the injury that they experienced. So this is like a classic on like our board exams and stuff. If they say that there's a loud pop and they have like a positive Lockman's or an anterior drawer test, like then you're just like, bam, ACL, move on. So that's the ACL and like why we would suspect that that's the culprit here. The PCL or the posterior cruciate ligament, I think of this as just doing again like the opposite of what the ACL is doing. So we would have a negative Lockman test because remember that one's assessing at like a slight bend of the knee. You can't really do it the opposite direction because that'd be hyperextending it. But that drawer test where you have your knee in a 90-degree position, if you can push back on it, that would be a positive drawer test sign for a PCL. And it also has the sag sign. I don't want you guys to worry about that because I couldn't really find like a good image to show what that looks like. But it's basically if you were to hold the leg up, that it looks like it's kind of pulled down relative to the knee and the rest of the leg because the posterior support is not functioning anymore. And so the leg is going to not be able to be held up in relation to the rest of the joint. And then the third one here was this medial meniscus. That would be the one that we see a positive valgus stress test, where you have the knee kind of twist out to the side that they did where you're supporting the ankle on the inside with one hand and the outside of the knee with the other hand, and you're trying to externally rotate or push it more out to the side. And if you get that instability there, then that's a positive valgus test. But you would have a negative Lockman and drawer test with the medial meniscus. And this one also, when I mentioned in the exam that our patient didn't have any locking or clicking of the joint during the range of motion exam, that can also, if they did have it, lead us to suspect a meniscus tear. And so that's just one of the other findings that can be associated with this. So after doing our exam, the way that we would confirm a diagnosis of either a ligament or a meniscus injury, which are soft tissues of the joint of the knee, is with an MRI. You might think it's like a sports injury, like why would you not get an X-ray? While X-rays are great for certain things because they're very fast and inexpensive, they are really good for bony injuries like fractures or dislocation of bones. And they are not great for looking at the soft tissues of the structures that support the bones. So for this type of injury, we would want to get an MRI and not an X-ray. So this is trying to just show you guys what an MRI might look like. The only anatomy that I want you to worry about right now is the arrow here that's pointing at the ACL. So this like sort of structure that looks kind of like a U, but it's just kind of like connecting the front and the back of the knee joint. That's normal, and it's supposed to have that sort of nice smooth shape. And in our patient here, so this is one that has like a partial tear, and you can see that it is, one has a lot of like inflammation around it, and two, it doesn't have that nice even shape that the first one has. So that's an MRI finding of like an abnormal ACL, abnormal ACL imaging. All right, so for our assessment and plan, we have a 17-year-old male with no significant past medical history who's presenting with 1 day of right-sided knee pain that began after this twisting injury while playing basketball. He described it as a loud pop followed by pain, swelling, and reduced weight-bearing ability. Exam was significant for redness effusion and a positive Lockman and anterior drawer test. And then MRI confirmed the diagnosis of a partial ACL tear. So our assessment here is just kind of summarizing everything from the history that was relevant, everything from his exam that was relevant, and then just saying what the confirmation of the diagnosis was, so that we kind of have what the final decision or the diagnosis is that we have, and then why we support this hypothesis. And then the plan for our patient is going to start with supportive care. So RICE therapy is the abbreviation that we use, or the like, I don't know if it's a mnemonic or what's the word that I'm looking for, but it stands for rest, ice, compression, and elevation. And these are just the sort of like supportive measures that we can recommend patients do at home to help reduce swelling and to help with pain and to prevent further injury. So they can do this at home, like kind of on their own. And then also every patient who has an ACL injury should also get physical therapy to help with strengthening the muscles that support the joint, and to make sure that they are not like overcompensating with structures that are not supposed to be used in a certain way to prevent further injuries. So RICE therapy and physical therapy. And then for pain, we can also have him continue taking the NSAID. So he's been taking ibuprofen in the last day, and that's the first line treatment for musculoskeletal injuries because they both help pain and inflammation. I'll go through a little bit of the pharmacology of how that works and like the side effects of it at the end of the presentation. But just to know that patients, like, this is the first line treatment that we have for pain for patients with these types of injuries. And then lastly, this one's kind of like a plus or minus depending on the patient and their unique situation and their age and their overall health and their overall lifestyle, if they were to get a surgical repair versus not. So ACL injuries can just be managed conservatively, and you don't have to do a surgery to repair it or replace it. Most people would be fine without having to get an ACL surgery. But in this patient, because, you know, he's young, he's an athlete, he is really active, and he has, you know, potentially a future where he's going to continue to want to play sports, that we would consider him as a good candidate for surgery, compared to somebody who's, say, like really old and not very mobile and has comorbidities that would be high risk for surgery. So This patient would potentially be a good candidate for surgery versus, I just wanted you guys to know that not everybody gets surgery. Okay, before we move on, does anybody have any questions about our case? Anything with the patient or the exam or our plan or anything like that? Okay. If anything comes up, please let me know either in the chat or you can unmute and we can always go back. And if there's anything also in the like assessment and the SOAP note or the quiz that you want to go back for like at the end of the presentation, then I can also go back to like any slides that you might want. So going through some epidemiology of sports injuries or ACL in general, I guess. So the incidence of ACL tears alone is between 100,000 to 200,000 people in the United States each year, which is about 1 in 3,000 people. And so like not super rare. You probably know somebody who has had this or like have heard of someone who's had this. And just in general, sports and musculoskeletal injuries across all age groups are some of the most common complaints that you see in primary care. So like as a family medicine physician, you might have a person who came in and they like had a fall on their wrist and they're having wrist pain, or maybe you have like a middle schooler who's in swimming, competitive swimming, and they're having shoulder pain. Those are all like super, super common things. And so it's really important to have a good background in musculoskeletal anatomy and knowing like how to diagnose and refer things for further treatment. It kind of depends on the cause, depending on like the age of the person and like what their lifestyle looks like. So in young people, like this patient that we just saw, it's oftentimes like a traumatic sports injury or sports related injury, especially sports that have high like shifting your weight and twisting and having sort of like more unpredictable movements. So things like soccer, basketball, and skiing are really big culprits of ACL tears. And then in older people, because they're often not like out on the court playing basketball really aggressively, but they can still have these types of injuries. It can be due to things like falls, or if they have a contact injury or blow to the leg, that can also be a cause. Some risk factors for ACL tears are being on either like walking or running or playing a sport on uneven or wet ground, a sport that has aggressive sudden movements. That is going to be a lot higher risk than things that are more like repetitive and predictable movements. And then some intrinsic or non-modifiable risk factors that are just unique to the person would be like their individual anatomy. So your like foot bone size, like for example, or like the strength of your ligaments may be like just weaker compared to other people. So that's something that you can't really do too much about. And then an interesting one that that I saw was that females actually have a slightly higher prevalence than males due to the hormonal fluctuations with their menstrual cycle. And I think it was that like right before ovulation, there's a hormone called relaxin that's released that can increase your joint laxity. And so females actually have a slightly higher prevalence for these injuries compared to males. So just to kind of orient you guys, I did not know these terms before I started taking like anatomy in medical school. And so just because there's anterior, posterior, lateral, medial, those sorts of things, I just want to make sure that everybody is on the same page with what those mean. So first looking at anterior and posterior, anterior is going to be closer to the front of your body and posterior is closer to the back of your body. So the anterior cruciate ligament that we saw that our patient has a problem with is going to be the ligament that's in the front of the knee and that prevents a forward dislocation or forward displacement of the leg, of the lower leg relative to the upper leg. Versus the posterior cruciate ligament or the PCL, that ligament is going to be in the back of the knee and it's going to prevent that backwards dislocation or displacement of the leg. So they kind of oppose each other, but they're both important because they both are going to contribute to the stability of the joint. They're just in different locations anatomically. And then the other ones to talk about are lateral and medial. So medial is going to be more midline, and midline meaning like right down if you were to draw the line of symmetry in the body. Medial is going to be closer to that, and lateral is going to be more on the outside or like farther away from that. So the MCL is going to be on the inside part of the knee joint, and the LCL would be in the outside of the knee joint. And again, that's going to stabilize in the direction of force that would be applied. So the MCL, when we do the valgus stress test, it's going to prevent that to hold that like inward force, and the lateral side would be that outward force. So remember, like when we were trying to have the leg be like externally rotated, we were pulling the ankle more out to the side. And if that ligament was not able to hold the lower leg and the upper leg or stabilize them together, then you get that instability and you're going to have the lower leg kind of coming out to the side where it's not supposed to do that. Don't worry about like superior and proximal and cephalic and all that. I just wanted to show you guys anterior, posterior, and then medial, lateral. So now looking at some anatomy here, first just to look at the ACL. So the ACL is this one here that we're seeing injury in. Again, it's going to kind of, this is looking straight on at the knee. And so the insertion of this is going to be up on the femur and down on the tibia bones. And in front of it, like you can't see it, but otherwise would be the patella or the kneecap, but they just have removed it for the picture. And so this is going to be in the front of the knee. And then you can kind of in the background see the one that's crossing it, and that's the posterior, the PCL. It's just not labeled here, but that's the one that's kind of going down and behind it. And all of the ligaments in the knee are made of tough fibrous collagen that connects this top femur bone to the bottom tibia bone. And that the job of these ligaments is to stabilize the joint and prevent that dislocation or displacement of the knee. So like we mentioned before, the anterior collateral or anterior cruciate ligament, the ACL, is going to stabilize and prevent anterior or forward dislocation of the knee. Here it's showing the unhappy triad, which is where if you get all three of these things at the same time, which can happen, a lot of like football players will experience this because of just the contact nature of their sport. But it's where you have an ACL tear, an medial meniscus tear, and an MCL tear. So definitely not ideal. And the meniscus here, so you have two menisci, I don't know, two menisci in your knee. You have the medial and the lateral meniscus. So this would be at a view looking at, what would that be? Let's see. This would be looking at the right leg, like you looking straight down at your right knee joint. So the medial is going to be on the inside of the knee and the lateral is going to be on the outside. And they're both these sort of larger, like pretty big actually compared to the ACL, large C-shaped structures that are made of smooth fibroelastic cartilage. And cartilage is a really like sort of glassy, slippery, cushiony type material, so different than the fibrous collagen of the ligament. That's job is to be like strength. This is going to be more of like a distributing or to absorb the force across the knee, so that if like you get a really big a lot of pressure like right here at the front, that the medial meniscus will help to distribute that to the rest of the joint, and so you don't have so much like pressure all in the same location. And then a secondary function of the meniscus would be if you tear your ligaments, that because now you have less like stability in the joint and you have more tendency to like dislocate or displace your joint in that direction, that your meniscus can also provide some of that joint stability, especially if you've lost this ligament. So it's very also common for patients who have like an ACL injury to have a concurrent medial meniscus injury because they are not able to have that joint stability, if that makes sense. And also medial meniscus is much more common than lateral meniscus. So just to know that that's more common. So what happens when you have a tear in one of these structures, specifically the ACL? If you have a tear or injury to the ACL, it weakens and disrupts the function of the joint, which is that joint stability. So you can have a sense of instability with weight bearing, and you'll also rely more on your surrounding structures like your medial meniscus and your other ligaments to compensate for the loss of the function of your ACL. So that's just functionally how your joint is going to be different if you have a tear. And then for your perception of it and how you feel, obviously it's painful. It's going to hurt because you just tore a ligament in your joint. And that trauma is going to cause local inflammation to that area. You're going to get swelling, and that produces that joint effusion, which is the fluid accumulation within the joint space that we saw on exam on our patient. And like I mentioned before, you can have a hemarthrosis, which is an accumulation of blood in the joint space. So I think that this one is, it's less common, but it can happen in like a more severe tear. Redness of the skin and the surrounding area, that can be caused by increased blood flow to the area because your blood vessels are responding to the immune signals that are trying to recruit cells to that area to help you heal it. And so you're going to get increased blood flow to the area. You can have like a red joint. And then of course, pain, it's going to hurt. That can be due to the recruitment of those immune cells to the area and also just damage to the surrounding nerves. So these ligaments do have their own innervation also. And so if you have an injury to them, then the nerves are going to send pain signals to your brain, and all of that is going to contribute to pain. And then on physical exam, we just see findings that reveal the manifestation of this injury, of this instability that we have in losing the anterior cruciate ligament. So instability in the anterior direction or the forward direction due to the lack of reinforcement between those two long bones, your tibia and your femur. So when you pull forward, that tibia is not going to have anything like anchoring it to stay put, so it's going to go forward. So what's the treatment for ACL tears or ACL injuries? We mentioned before RICE. RICE stands for rest, ice, compression, and elevation. This is going to help to reduce the swelling and inflammation of the knee to help control your pain. And it will also prevent further injury from overuse of your other knee structures. Again, physical therapy is going to allow you to keep your strength of your surrounding muscles, especially the quadriceps, which are really important in having a strong and stable knee joint. Fun fact, actually, in people who have like really bad arthritis of the knee, it's first line therapy to get them to do quadriceps strengthening exercises, like better than any like cortisone shot or anything like that. If they can just have better use of your quad muscles and of the surrounding muscles that help support and stabilize your leg, that's like the best #1 therapy that we can do. And of course, physical therapists, you know, they're experts in the way that your body is supposed to move and in healing from injuries and preventing further injuries. So they can also help with guiding this patient in like when he goes back to training, like to make sure that he's not doing certain exercises or movements that might exacerbate this injury or to cause a new injury. And then, like we said before, NSAIDs. So this stands for non-steroidal anti-inflammatory drug. And that is a family of drugs that includes things like ibuprofen, naproxen, which we mentioned before is Advil and Aleve. Also a drug called ketorolac that goes by Toradol, if you've ever heard that before, and diclofenac. These are all basically the same thing. Also aspirin, I left aspirin off, but like a regular dose aspirin also is an NSAID. And the function of this is going to be like up here in this diagram here, we have inhibition of these enzymes called COX-1 and COX-2. And this is the enzyme that helps convert certain molecules into prostaglandins. Prostaglandins are an inflammatory molecule that contributes to pain and inflammation. So by blocking the formation of prostaglandins, we have less pain and less inflammation. Unfortunately, NSAIDs, as effective as they are at their job, they can also be dangerous if overused or if taken in too large of quantities or for too long of time. So the things that we really worry about in people who are on chronic NSAID use are things like GI ulcers, so like stomach ulcers or other areas of bleeding in the GI tract. And then also these are excreted through the kidneys. And so you can have increased susceptibility to kidney injury if you are overusing NSAIDs. So in some people who have, chronic pain or who like just taking an Advil isn't cutting it for them, sometimes we'll also have them alternate with acetaminophen or Tylenol. And that kind of takes the load off of like your one organ just having to be responsible all the time. So Tylenol is metabolized in the liver, and NSAIDs are metabolized, or I guess they're excreted through the kidneys. And so by kind of alternating them, it gives each organ a break, so to speak. And then lastly, I mentioned with surgery, so arthroscopy is the name for the surgery that you do in patients who have like a joint surgery, I guess, or a repair. So this is a minimally invasive surgery where they just make little incisions near the joint opening, and they insert tiny cameras into the joint space, and they have tiny like microscopic surgical tools to debride and to fix the injury. And but despite it being minimally invasive, you still have to go under anesthesia, and there's still, an extensive recovery process. So the people whose surgery is indicated for are people who are younger, who are healthier, who have a better chance at recovery, who are athletes who really depend on that full regain of function of that joint or of that part of their body. And so like our patient would be definitely a good candidate for surgery if they, opted to do that. It's not required. And a lot of people who are older and who have comorbidities or who are sedentary or who have, a poorer chance at recovery are not going to be as good of candidates for surgery. So these things that are on this left side here are really the bread and butter of treating sports injuries. So to finish our case, our patient benefits greatly from the supportive cares that we just talked about and has great control of the pain and has gained back a lot of weight-bearing ability, and does elect to undergo a right knee arthroscopy and ACL repair, and he's now recovering before returning to sports. So that's another thing that is challenging in sports medicine and orthopedics, is that patients oftentimes, like, they just want to get back to whatever it is that they were doing. Like, they want to get back in the game, they want to finish their season, they want to compete, at their state tournament or something. And a lot of the times it's having them understand that, like, in order to regain your function and to not have further injury, that you have to sort of invest the time up front in getting better and healing, so that you can be more optimized later down the line. And that's really challenging because so many people, like, they just want to get back to what they love to do. But on the flip side of it, you see people who are really grateful that they get care in the way that they do and are able to listen to those recommendations, even though it's unfortunate at first, and they're able to go back to doing what they love later down the line. So a little bit about orthopedics and sports medicine. Some things that you do: obviously diagnosing and treating people of all ages with painful, immobilizing, or debilitating musculoskeletal problems. So in orthopedics, you might see people who have really bad arthritis and they need like a knee replacement, or maybe you have like a, I don't know, like an 8-year-old who tore their meniscus. Like, you can really just get the full spectrum of people who have musculoskeletal problems. And what's great about these is a lot of the time you can make a diagnosis with a definitive treatment and have great interventions for them. Unlike other parts of medicine where the patient problems can be so complex and they can be so difficult to treat, that in orthopedics, you kind of are just making like a very tangible difference in a specific problem that people have. And like I was talking about before, like people are really grateful for their ability to return to their passions and to their lives. And maybe you'll treat like professional athletes who otherwise would have ended their career, and now they are able to go back and do what they love. So those types of things. And specifically for orthopedic surgery, if you like being in the operating room and you like having that hands-on interaction with patients, that you are the person who is operating and can make that immediate impact in their care. So the road to doing these types of things starts with obviously 4 years of medical school, either MD or DO. And there's so many different ways that you can do sports medicine. Like if you were doing non-surgical sports medicine, family medicine can practice that, pediatrics can practice that, internal medicine even. I would say like it's probably those first two are more common, but internal medicine can also do some element of musculoskeletal care. With these types of residencies and with these practice models, you're going to have a lot more clinic and referring people who need that procedural intervention to an orthopedic surgeon, for example, because you're not the one actually doing the surgery. But like everything in the case that we talked about, like the exam and the imaging and the treatment, besides the surgery, would be in the scope of a family medicine, sports medicine doctor or a pediatric sports medicine doctor. Another option would be physical medicine and rehabilitation. This is something that a lot of people have never heard of before, and it's a 4-year-long residency that focuses not just on like sports injuries, like that's probably actually not a huge part of what they do, but especially in people who have like car accidents or stroke victims, people who have like life-altering bodily impairments with their musculoskeletal system, and they need to have like intensive inpatient rehab, or they need to have very intensive therapy. That would be like in the realm of a PM&R or a physical medicine and rehabilitation doctor. I've actually never seen this before, like I haven't done it in a rotation before, but I think it's super interesting. And I think from my understanding, like you make a huge difference in these patients' lives. Like if you were in a car accident and you couldn't walk, and then, you know, with intensive therapy and with treatment, you're able to, you know, walk again. Super, super, super cool. And then the surgical option here, which is also the longest one, is 5 years of residency to become an orthopedic surgeon. This is the only one of those where you can actually operate and perform the surgeries yourself. But you can still have a mix of doing things in clinic and seeing patients in like an outpatient setting, and then also be able to have that continuity with them and do the surgery and follow up and all of that sort of stuff. So as an orthopedic surgeon, you would get the referrals from people in like family medicine, pediatrics, and sports medicine like that who need a procedural intervention. And then, you know, you kind of work alongside of them. And for all of these, if you know, as like a family medicine doctor without fellowship training, you would still see people who have sports injuries or sports problems or musculoskeletal problems. But if you wanted to only do that, then it would be an extra 1 to 2 years of fellowship so that you're just exclusively working with those people. These are my sources. And that concludes our presentation for today. I hope that you guys enjoyed learning about sports injuries and sports medicine. And please take some time to fill out the feedback in the SOAP note and quiz, because that's how I get my ideas for which topics to do at virtual rounds. So if you have any ideas or suggestions of things that you'd like to talk about, please make sure that you add them in at the form. And if there's any questions whatsoever in this presentation or for your quiz or for anything, please let me know. It was great to have you guys, and I hope you all have a healthy holiday season coming up.